The meningiomas of Convexity and Parasagittal need the treatment. I preface of child digits and speak. It's easy and difficult problem in medicine. Meningiomas arise from arachnoidal cap cells, more than 2,000 scientific research involved. The data are contradictory. Meningioma present a common intracranial tumor in the adult population. It's more frequently primary brain tumor in the United States of America. 20% of all brain tumor in men and 40% in women. MRI study is general population prevalence of 0.9% meningiomas and 1.5% of tumor in childhood. Women and men ratio 2 to 1. More malignant forms are from common in men. White is 79%. The peak occurrence in 65 years. We now including up to 8 per 100,000 people in elderly. Location, convexity, and parasagittal meningiomas begin 56%, malignant 79%. In time of cell doubling for grade 1 is from 450 days to 8 years. Risk of develop increase. Molecular genetic DNA, date, ionistic radiation, injury from central nervous system. The hormone role is not defined. Treatment options: surgical treatment, radiosurgical treatment, stereotactic radiotherapy, proton therapy, conventional radiotherapy, observation, endovascular treatment, chemotherapy, multidisciplinary approach. Each new recommendation of an NCC for treatment meningioma includes symptom and size of tumors. Neurosurgical treatment. The gold standard for symptom patient in the complete tumor resection, but in elderly population where complications are more frequent. Its variants of surgical treatment: any meningioma, Simpson 1, Simpson 2, Microsoft complete removal, Simpson 3, Microsoft complete removal of intradural tumor, and particle removal on biopsy, Simpson 4 and 5. The World Health Organization classification begin meningiomas up to 92%, grade 2 atypical meningiomas up to 72%, grade 3 meningiomas anaplastic malignant up to 3% of meningiomas. More than 9% of meningiomas is characterized by aggressive clinical behavior, which increase risk of tumor recurrence. Most of the convexity and parasagittal meningiomas can be removable in contrast to the location of the base and skull. Many surgeons prefer open excision of tumor, excluding tumor recurrence. Most patients want to avoid trepanation and if have alternative treatment. In the case of residual recurrence tumor, radiosurgery, radiotherapy, hypofraction unconventional, which the location of tumor near the vessel, functional zones, and sinus sagittae superior, total resection is difficult. Surgical treatment of asymptomatic meningiomas. In surgical treatment of asymptomatic meningiomas, the mobility was rate up to 4% in patients young than 70 years ago and up to 9% in those 70 years age at older. Existed relapse after surgical removal, grade 1 and Simpson 1 up to 8%, 5 years, grade 1, Simpson 1, up to 25%, 10 years, grade 1 and Simpson 2 or more, up to 50%, 5 years. And grade 2, Simpson 1, up to 40% relapse 5 years. Grade 3, Simpson 1, up to 80 for 5 years. After surgery, control MRI of brain with contrast one time in 1 or 2 years, even with Simpson 1 or 2 and grade 1. Relapse after surgical removal depends time after surgery, symptom criteria, will have organization grade and molecular genetic date. Meningioma middle and posterior third of sinus sagittal superior. If a sinus is partially or completely occlused, may be opened and total tumor resection follow the venous reconstruction. It's very difficult, but patients have alternative stereostatic radiosurgery or stereotactic radiotherapy. Endovascular treatment of meningiomas and radiosurgery. Angiographic embolization reduce of need of fraction during operation. Embolization is recommended in order to decrease the volume of the tumor and surgical blood loss. Location of endovascular treatment are hemiparesis and edema. Embolization reduces the number of vessels in the tumors and radiosurgery will be less effective. Observation, wait and see, and radiosurgery. Observation, wait and see, and very popular in medicine. Control MRI of brain with control enhancement once every 6 or 20 months. Possible option where tumor volume does not change. Appearance of growth neurosurgical symptom, tumor increase in size and volume, appearance of enlarged perifocal edema, and grade may change. Observation, wait and see. Often meningioma are ascending finding of the have focal symptom. 66 of case meningiomas did not grow, but after counting growth plus 2 mm at least L1 liner size, comparison of only liner is not objective, with an increase in diameter of ball 10 mm by plus 2 mm, increase in volume plus 53%. Research OS, observation of more than 3 years, increase in liner size only 44%, increase in volume was 74 meningiomas. Factor of greatest growth men plus symptom plus edema. High risk for symptom development is most common for young people because of the higher growth potential. Tumor growth is possible in from 24 to 76%. Safe observation possible if patient age with calcification and asymptomatic meningiomas. Wait and see or radiosurgery. Asymptomatic meningiomas, 3 years surveillance in growth after radiosurgery, 100%. Wait and see, only 61%. Actual tumor control 5 and 10 years after radiosurgery, 95% and 84%. Actual 5 and 2 years without treatment, 91 and 77% salvati. We use radiosurgery in justified in asymptomatic meningiomas. Radiosurgery. Radiosurgery is alternative to surgery in case of small and medium-sized meningiomas without edema and asymptomatic tumors. Research and across 4,565 patients, more than 1,000 meningiomas, more than 800 convexity and parasagittal meningiomas, 50 European gamma knife center, sporadic was up to 90%, meningomatous was up to 9%, nervinomatous type 2 was 1.3%. Medial tumor volume was 4.8 cubic centimeter. Marginal dose was 14 gray. Follow-up period was 24 and more. Median 63. 71% meningiomas were analyzed. 5 or 10 years progression-free survival were 95 and 88%. Clinical follow-up was 84%, range from 6 months to more than 200 months. Clinical improvement was 53%. Complete resolution of symptom was 22%. Complications were 12%, 6% permanent, and 6% temporary. Morbidity for convexity and parasagittal location was 15%. After radiosurgery meningioma, tumor control was higher for grade 1 family sporadic meningiomas at skull base. The volume of treatment tumor decreased in 58%, stabilization 34%, increase in 7.5%. 2% need retreatment. Control was 92%. Edema after radiosurgery. More often with parasagittal meningiomas, more often asymptomatic and transient. With the expansion of tumors with edema before treatment up to 28%. In meningiomas have edema and or neurosurgical symptom before treatment, surgery is preferable, since after radiosurgery repeat regression is not possible. Risk edema after craniotomy with residual tumor of relapse in case radiosurgery is lower. Edema after radiosurgery depends on size tumor and correlation with marginal dose. Significant risk factor for post-radiosurgical edema, age older than 60 years, no prior surgery, pre-lesional edema before radiosurgery, tumor volume grade 1, 10 cubic centimeter, marginal dose is grade 1, 60 gray. Variant of relapse after radiosurgery out of field tumor progression treated radiosurgery, in field tumor progression treated surgery. Conventional radiotherapy. Radiotherapy recommended as additional therapy in grade 2 and 3 meningiomas, mainly in incomplete surgical excision is performed. In patients with high-grade atypical meningioma, radiotherapy improves patient survival, only if there was brain involvement. In grade 2 meningiomas, radiosurgery proposed because is where the late tumor growth of the reduce of likelihood for future surgery. only 10 of 56 medical centers in peace recommend radiosurgery after surgery with grade 2 meningiomas. Grade 3 relapse up to 52%. Grade 3 relapse after 9.4%. A high relapse rate correlates with a decrease in life expectancy. Grade 2 and 3 often require a combination of surgery plus radiotherapy and multidisciplinary approach. The tactic of treatment depends on the radical nature and surgical and histology. Research ACHI, grade 2, symptom 1, 108 patient, a small group, 200 without radiotherapy, relapse of 50 people, and 8 patients plus radiotherapy plus 10 centimeter round resected cavity, relapse 0. The result and tactics of the use of radiotherapy and surgery with meningiomas grade 2, 3 and optimal time interval after craniotomy is still being studied. Atypical and anaplastic meningiomas. Management strategy for grade and 3 meningiomas: first, surgery, histological verification, radiation, recurrence, surgery of radiosurgery, recurrence, surgery of radiosurgery, and very difficult treatment. Grade 2 and 3. Definition of histologic active is important factor in determining biological behavior. It is not always possible to determine histological chip. Histological evolution is not always objective, where is correlation between histology and aggressive histological behavior. In the wolf, the problem of using Ki-67 and genetic methods, for example, grade of probably recurrence, up to 18%. The increase in the Ki-67 index correlation with the risk of recurrence and overall survival. Height indication of Ki-67, IB1, P53, BCL2, characterized by resistance of radiotherapy and radiosurgery. Molecular genetic tender of meningiomas. For information, genetic change underlie development of meningiomas, arachnoidal cells, genetic change, and meningioma grade 1, grade 2, or grade 4 or 3, and genetical change. One surgery is not enough. Patient need a combination with radiotherapy and radiosurgery. Relapse can be after any radiotherapy and radiosurgery. Chemotherapy is not effective for meningioma, but in some centers it is possible use in the effect of radiotherapy and radiosurgery. Treatment any meningioma depends on size and volume tumor, location of tumor, critical structure of brain, neurosurgical symptom, edema before treatment, age and disease of patient, MRI. Doctor think what grade 1, but will be grade 2 or 3 after in 2% cases. Possibilities, effective safeties of neurosurgery, Simpson 1 or 5 after operation. grade after operation, residual or recurrent tumor after surgery, calcification of meningiomas, molecular genetic данных, choice of patient and doctor. Observation has risk, if not calcification. Radiosurgery is alternative of surgery, small and medium-sized asymptomatic tumor without edema. Stereotactic radiosurgery and stereotactic radiotherapy is effective for recurrence and residual tumors. How do we treat if grade 2 or 3 and Simpson 1, 2, where is not target but where cells, high frequent on recurrence, conventional radiotherapy on observation, recurrence surgery of stereotactic radiotherapy or stereotactic radiosurgery. Please you for attention.